So another important topic in your general survey is edema. How do you define edema? How do you detect edema clinically? You press above the medial malleolus for about 15 to 20 seconds and then you leave it. We usually use our thumb to press over the medial malleolus. But in children, we get various types of edema. In adults, you have already learned that above the medial malleolus, if you detect a percussion note in the skin, that is, the skin gets indented, that is edema. But in children, you get various types of edema. So I will discuss edema now in detail. So number one is pressure has to be applied for at least 15 to 20 seconds. What are the sites? Number one is pedal. Number two is sacral. And number three is parietal. So we have three types of edema in children: pedal edema, sacral edema, and parietal edema. What are these three? Pedal edema, you have already learned in the adult. In general medicine, you have learned that pressing above the medial malleolus, you get pedal edema. Sacral edema, you only get in the sacrum in non-ambulant babies. Non-ambulant babies, the baby who cannot walk around, sit up, or play. If the baby cannot play or baby is not ambulant, does not get up from the bed, automatically the baby is lying down and the sacrum is the dependent part, and so you get sacral edema. What is parietal edema? Parietal edema is you use the bell of your stethoscope. The bell of your stethoscope, you press it on the tummy, on the just around the umbilicus, anywhere on the abdomen, and you see the impression of the bell comes on the abdomen. Impression of the bell. That is called parietal edema. What does these three types of edema mean? Number one. Number two is there are two other types of edema: pitting edema, non-pitting edema. Pitting is that we press, that is called pitting edema. Pressing and removing your fingers after 20 seconds, that is called pitting edema. Non-pitting edema is tightly adherent to the underlying structures, and we get that in acute post-streptococcal glomerulonephritis. Acute post-streptococcal glomerulonephritis occurs in school children. Why? Because streptococcal infection occurs in 5 to 15 years and it is very infectious. Small children get impetigo, small little impetigo on the feet and the hands. There may be a remaining scar. Scabies might be added to it. Scabies is another infection. So scabies may be there in the furrows of the fingers, the burrows of the scabies may be present in the fingers and the toes. And so if there is scabies, infected scabies and impetigo, these are also infections of school children which goes from one to the other. And then after that, a hypersensitivity occurs, inflammation, and the glomerular basement membrane becomes thick with antigen, antibody, and complement. Once the basement membrane of the glomerulus becomes thick, I need a board actually to explain to you. But since I do not have a board, I'm showing you with my fingers. The glomerular basement membrane has three layers: the antigen, antibody, and the C3. These are the three components of the thick basement membrane of acute post-streptococcal glomerulonephritis. Automatically, the glomerular filtration rate is reduced. If the GFR is reduced, you get a renin-angiotensin mechanism and sodium and water is retained into the body. Sodium and water retention into the body causes edema in acute post-streptococcal glomerulonephritis. What the mother will say, she will just overlook the sore throat, the streptococcal sore throat that the baby had, little bit of aches in the throat and a little bit of malaise or fever, or little bit of impetigo which leaves a small impression. Maybe it's not scabies, it doesn't cause a lot of itching at night. So the mother will overlook it. Mother will come and tell us that the baby has a bloated face, moon face of acute APSGN, we call it in short, APSGN, moon face of APSGN, and edema throughout the body, but it is very tight and adherent to the body. It is not pitting everywhere. But she will complain of a red currant jelly, not exactly red currant jelly, it is used, another adjective is used, it is cola colored urine. Cola colored urine. You know the color of Coke? Everyone knows the color of Coke. It's a reddish brown color. The urine becomes red colored and the urine becomes oligarine. That is, oliguria or anuria accompanies this edema. This sudden onset of edema is accompanied by cola colored urine and decrease in the volume of the urine. How is the volume measured of the urine? It is measured by diapers in small children. The dry diapers you wait, and after 6 to 12 hours, you weigh the wet diapers and you get the urine volume. Urine volume should be less than 0.5 to 1 ml per kg per hour. Per hour, that is 1 hour, it should be less than 1 ml. If it is less than 0.5 ml, that means the baby is more oliguric and gradually there may be retention, complete retention of urine. Retention of urine occurs for hours in male children or in female children because the female urethra is very short and straight, whereas the male urethra is curved and long. So, this retention of urine or the increase in the age, babies become dry by day by 2 years of age and dry by night by 3 years of age. This nocturnal enuresis, if it increases, the age of it increases, that you ask the mother, does the baby wet his bed? One mother will say, no, long back the baby used to wet the bed. It's long back. The baby is now 10 years old. Maybe 2 years only he was dry. One mother will say. One mother will say, last 2 to 3 years back, during the rainy season when it rained very heavily or it was cold, sometimes the baby wet the bed. So you ask the mother, what did you do for that? Mother hasn't done anything. Mother just overlooks it. We say, number one, you make the baby urinate before the baby goes to sleep. Number two is, the day the baby wets the bed, you put a red mark on the calendar, a black mark on the calendar. And the day the baby does not wet the bed, you put a red mark. As the black marks decrease and the red marks increase, baby will be dry. Another thing that you can do is bladder exercises. That is, in the daytime when the baby is having the urgency to go to the washroom, you tell the baby you go after 1 minute, go after 30 seconds, 1 minute, 5 minutes or 10 minutes. You gradually increase the detrusor capacity so that the detrusor doesn't contract whenever it is cold or whenever a tap is running. Supposing a baby is anuric or retention of urine, what we tell the mother is you go to the washroom, open the tap, and immediately the detrusor contracts and the baby passes urine. This is a very, very old way of treating anuria or retention. But the problem is, anuria or retention means cystitis. That is, the bladder wall is inflamed, and that is why the detrusor has not stopped contracting. The sphincter has not opened for hours. This is number one. That is, the initiation of infection in a boy or a girl starts from school age. Simultaneously, impetigo and sore throat starts from school age, 5 to 15 years. You get two diseases. Number one is acute post-streptococcal glomerulonephritis. Another is rheumatic fever. Rheumatic fever is a disease which licks the joint and bites the heart. You have stopped seeing rheumatic fever now because a lot of streptococcal infection is being addressed. Whenever a baby comes with sore throat or the fauces of the tonsils with pus points are meeting in the center, you immediately give amoxiclav, that is clavulanic acid along with amoxicillin to treat the streptococcal sore throat. Or if it is a skin infection, you use mupirocin skin ointment to treat the impetigo, and the impetigo is much earlier addressed than before. Like say 10 to 15 years back or maybe 30 years back when we were house staffs, we saw a lot of rheumatic fever, but you don't see very few now. In addition to it, penicillin has been replaced by third generation and fourth generation cephalosporins. Whenever a baby is sick, some doctor, some GP will write cefodoxime or some GP will write cefuroxime, and naturally the streptococcal bacteria gets curbed. So you don't get a lot of rheumatic fever, but acute post-streptococcal glomerulonephritis is continuing and causing edema. Another important cause of edema in this age group is first attack of nephrotic syndrome. What is nephrotic syndrome? Nephrotic syndrome is similarly, like we said, mooning of the face in acute post-streptococcal glomerulonephritis. Here in nephrotic syndrome, the whole body is anasarca. Anasarca means swelling of the whole body. In addition to it, SAM, that is severe acute malnutrition, is another cause of anemia in small children, that is under 5 children. Under 5, you have two causes. One is SAM, that is severe acute malnutrition. Another is nephrotic syndrome. Which nephrotic syndrome affects under 5 years or under 8 years is minimal change nephrotic syndrome. Minimal change nephrotic syndrome is not detected clinically. You have to do either a kidney biopsy for final diagnosis. You show the fusion of the podocytes, that is of the foot processes of the glomerulus. In the glomerulus, you see fusion of the, again I regret bringing a white board and drawing it with a chalk, but I will show it next time. In my next video, I will use the whiteboard and a marker pen to show you the podocytes. But SAM we can easily understand. Both are conditions in which hypoalbuminemia occurs. In case of nephrotic syndrome, the albumin is low, but where does the albumin become low? And in SAM, severe acute malnutrition, it is deficiency of the protein and the energy, calories in diet. In diet, that is, it was first discovered in Ghana children, in African children, who used to eat a lot of potatoes and tubers. They became swollen up, that is, they got kwashiorkor, that is severe acute malnutrition, the edema due to the calorie, deficiency of the calorie. Because carbohydrate gives 4 calories per gram, proteins give 4 calories per gram, and lipids, that is the oils, give 9 calories per gram. So there is no question of lipids in South Africa or Ghana. It is a very poor country. Till date, I went to Masai Mara recently. We saw their lanky children, lanky adolescents, very lanky, tall adolescents carrying huge loads on their backs. And the children in the villages, their cow dung has not been removed. Cow dung, it is there. And the cows are there for giving milk to the babies. Cow's milk is available for the children and the adults. But their cow dung is not cleared. So a lot of flies accumulate on the cow dung, and the babies are bald-headed there. Most of them just, use the razors to make them bald, the infants and the toddlers. And the flies from the cow dung, they are flocking on the heads of the babies. Can you imagine how dirty, how much poverty, and how much lack of hygiene they have? The Africans till date. I went to Masai Mara this 2023, July, to see the migration. But instead of the migration, I saw how poor they were. They are poorer than India. They are poorer than India. You know, the flocks of cattle, they go from Kenya to Tanzania where there is rainfall. We went to Masai Mara, which is in Kenya, Nairobi. We couldn't see the wild flocks. They were lining up, for the migration. All the bullocks and all the creatures, they were lined up in queues. But they couldn't cross the rivers because there were crocodiles on the opposite side of the river. They could not cross it, migration. But just the day we came back, the crocodiles had gone and they crossed, and we saw the migration in videos sent by the Africans the day we came. But instead, I saw the poverty of the Africans. Poverty, lack of schooling, ignorance, lack of jobs. Jobs are also not there. It is a very hilly country with lots of shrubs and forests, where I did not see any grasslands with paddy fields like we see in India. Not one paddy field I saw, only shrubs and forests on the hills. So how poor they are and how they survive. I just couldn't think that how much height that puberty gave them. Puberty is a endocrine factor. That is, the babies from 9.5, the babies become tall till 15 years, 18 years. So they became tall, but they are lanky and thin. But they have a lot of power because they know how to survive. You know, survival of the fittest. They don't get calories, they don't get proteins, but they survive, and they are surviving till date. So this is a story that I told you of my recent voyage, because I think a little bit of story makes like a little bit of sugar makes medicine more tasty. A little bit of story makes studies more nice, isn't it? Don't you think so? So we will continue with edema. So edema in minimal change nephrotic syndrome, it is the podocytes which are fused, and over there what happens is the albumin, it leaks. It is called selective proteinuria. Selective proteinuria, that is only 68,000. What is the diameter of albumin? 68,000 angstrom units. Albumin. Albumin and transferrin and few other immunoglobulins, they are leaked out. So nephrotic syndromes are immunocompromised because the complements and immunoglobulins are leaking through urine. So they have selective proteinuria. And if the albumin goes out, albumin causes the main oncotic pressure which keeps the blood fluid inside the blood vessels. Once the oncotic pressure goes down due to the loss of albumin, the hydrostatic pressure pushes out the water into the third space and the tissues, and obviously edema occurs. So both cases, there is edema. In severe malnutrition, there is absence of albumin or protein in the diet. In nephrotic syndrome, the albumin is leaking through the urine, and automatically leaking through the urine means the oncotic pressure is less and the hydrostatic pressure is pushing out. Both cases you get edema. Both cases you get edema, but the cause is different. Cause is different. Now I will come to a case, a clinical case. A baby, a 13-year-old, not exactly a baby, a 13-year-old adolescent girl came to National Medical College in 2003-04 with bilateral pedal edema. Bilateral pedal edema is both her feet were very swollen, and we immediately suspected malnutrition because the baby was very lanky. You know that puberty causes increase in height. So the baby was 13 years old. The baby had no signs of puberty, no thelarchy, no breast development, nothing. Only 2 fat legs showing, 2 bipedal edema. But we screened the baby for everything. We did a LFT. We could not see a low albumin count came. Hypoalbuminemia came, but the disease could not be diagnosed. That whether it is due to another condition in adolescence is the increase in height that occurs, height and weight, due to the LH-FSH surge. The amount of food that is provided by the parents is not always adequate. Similarly, when the baby is breastfed for 6 months, the breast milk is adequate for the baby. Similarly, complementary feeding has to start at 6 months. If complementary feeding, that is rice, cereals, and pulses, and green vegetables, and red vegetables, and dairy products, and oils, and fleshy products, if it is not introduced very gradually to the baby, very, very gradually. Why? I will tell you why. Because the baby was sucking milk. How was the baby sucking milk? Baby was using his mouth, his tongue, and the hard palate. And the areola, the mother's areola was inside. And the baby was pressing milk from there. The tongue was sticking out. But when the baby gets the complementary feed, that is the rice or the banana, how does the baby take it? Baby uses his saliva to make a bolus. What is a bolus? Like mothers make small boluses to give to the baby when the baby is grown up. I will tell you a secret. One 31-year-old doctor in our hospital, she is fed by her mother even now with sheddo bhat. You know what sheddo bhat is? Boiled rice with potatoes and vegetables and everything. And she just glorifies with that. That my mother's hands taste mixes with that bolus, you know. So what happens to that bolus? In that young age, in that 6 months age, that bolus rolls behind and puts that bolus into the esophagus. That is how swallowing starts. Sucking, that is sucking the milk from the hard palate and the areola by the tongue, sucking the milk, swallowing the milk, and rooting. Rooting means looking for the mother's nipple. Do you know how we see rooting reflex? In the villages, there are no clean area in normal deliveries where you can put the baby. You have to put the baby on the mother's abdomen because that is the only clean area in the vicinity where you can keep the baby. And the baby, you cut the cord after some time, within 10 minutes or 15 minutes or 5 minutes, whatever it is, you cut the cord or you clamp the cord, and then the baby climbs up from the abdomen up to the breast by the smell of the breast milk and goes and sucks that colostrum. And what does he get? What does he get? He or she get by that colostrum? Secretory IgA, which is very important for life. The baby's stomach size is only the size of a marble. Many people think all over India, Asia, and even in America and Africa, they think pre-lacteal feeds because the colostrum is very small in amount. It is yellowish, it is sebaceous, and it is a bit oily. It is very small in amount, but that is enough to feed the marble-sized stomach of the newborn. Marble, you have played with marbles, all of you in your childhood. So you remember your marbles. So this baby's stomach is like the marble. The mother will often say, my milk is not enough. I'm not sure the baby is getting enough milk. What you tell the mother is, first 15 days, the baby will lose its weight, and after 15 days, it will gain about 30 gram per day for the first 3 months and 20 gram per day for the next 6 months. So the baby's weight becomes double by the 6 months and triple by the 1 year. So much of increase in the first year of life. Why? Because the neuroplasticity of the brain is increasing in the first year. And in the second year, the height will increase from 50 centimeter to 75 centimeter. But in the second year, it will be only half of the 25, only 12.5, that is 87.5 in the second year. So the baby's head circumference increases from 35 to 47.5. The brain is increasing in size, 47.5, and only 49, only 2 centimeters in the second year. That is 35 to 47 means 12 centimeters head circumference. Height, what I told you, 50 centimeters to 75 centimeters, 25 centimeters in the first year. And head circumference, supine length, and similarly, you have the chest circumference also. The chest circumference I will not discuss because it crosses around 3 years, and so I will not discuss it. Upper segment and lower segment also I will not discuss. I am discussing edema now, so I will come back to edema. So what did I tell you? Edema, breastfed babies, I told you if the breastfeeding continues, when the mother gives, many mothers will say, we have breastfed till 2 years, 3 years. That is not good. That is not good. Why not good? Because if that complementary feeding is not given at 6 months, baby needs how much calories at birth? At birth, the baby needs 100 calories per kg. Supposing a baby is 3 kgs, baby needs 300 calories. The mother's milk is maximum 600 to 800. Mother's milk gives 100 ml will give only 70 calories, both cow's milk and mother's milk. Those mothers who join early at 4 months or 6 months, they often give top feed or artificial milk. That will be only 70 calories per 100 ml. So if a mother produces 600 ml of breast milk, that will be 6 into 70, that is 420 calories. But due to the weight increase and the head circumference increase in the baby in the first 6 months of life, doubling the birth weight, that is, if the baby becomes 6 kg, how much will the baby's calories need? 600 calories. 600 calories cannot be supplied by that 600 ml of mother's milk. So we need to give extra calories by complementary feeding, which may be a little bit of parboiled rice. That is the middle of the rice, which is the handi, we say, the handi of the family. Handi of the family, the middle rice is a bit parboiled, a bit more boiled, a bit softer and semi-solid. You just put 2 little drops on the tongue of the baby, and with the saliva, the baby will form a bolus and the baby will throw it at the back of the throat. So this is how the bolus forms, and you 1 week you add only one food. That is, first week you add, supposing you add cereals, rice. Next week you add pulses, that is dal. Next week you add a little bit of bananas. Week means 7 to 10 days, not 7 days exactly. If the baby vomits or lose motions, immediately stop that new food and give it another 10 days back. And how will the baby get the calories? You have to add a little bit of lipids. I told you lipids give 9 calories. So just half a teaspoonful of oil. Where will you give it? Butter. Babies love biscuits with butter and sugar. You give them the biscuits. At the 9 months, the baby already has the immature pincer grasp. Baby can hold the biscuit like this. And at 1 year, the baby will hold it like this, the biscuit. So a little bit of butter and sugar means baby will lick the butter and throw the biscuit. That is what he does. He will lick the butter, the sugar, and throw the biscuit. Doesn't matter. The lipids have gone inside the stomach. That will give the calories. So by 9 months, the baby self-feeding has started. So you use a 2-spoon method. The baby will feed himself as much as he can by 9 months to 1 year. And the mother, the rest of the food, the mother will give. That is the dal. And in fact, we adults need 2,400 to 2,200 calories being an adult. And the baby needs a 10 kg baby, that is a 3 kg baby becomes 9 kg at 1 year. I told you 3 times. So 9 kg baby needs half of that, 50%. Do we give a 1-year-old so much of carbohydrates, so much of fat and so much of proteins? We don't. So this is when the malnutrition starts. Malnutrition, micronutrients. There is another term coming up which is called micronutrients. Micronutrients is present in these green vegetables, red vegetables, dairy products, oils, cereals and pulses, and fleshy food. Fleshy food means you don't give, first only you don't give chicken, or chicken you don't give Manchurian chicken to a baby. Do you give Manchurian chicken to a baby? You don't. What you do is you give an egg. You know, eggs are available everywhere. Eggs of them, they have 2 components. One is the albumin, the white of an egg, and the other is the cholesterol, that is the yolk of an egg. So if you give the yolk first, naturally the albumin will cause a lot of allergy and reaction. You want it later in life, because the more the immunity the baby gets after 1 year, it is better to absorb the albumin. So you give the yolk first. Yolk, you give it first. You boil the yolk nicely. You mix it with the rice, you give it. Only half spoon at the beginning. It increases to 1 spoon. After 2-3 days, it will be in the morning, in the evening. And this is how it goes on increasing to 1,000 calories. 1,000 calories if the 1-year-old baby does not get, baby will have signs of micronutrient deficiency. What are these signs? These may be chillosis, vitamin C deficiency, that is scurvy. Scurvy means thick edematous gums, bleeding gums, thick edematous bleeding gums, and simultaneously the baby will get dry eyes. I will give you a few pictures of those dry eyes so that you can understand xerosis or xerophthalmia. You have learned in community medicine, you have already learned the 5 stages of vitamin A deficiency. So these are all met with these micronutrients, vitamin A, then your oil, then your proteins, all of them are required for meeting with these micronutrient deficiencies. In addition to this, you will hear the medical representatives harping to you about DHA, and DHA is required. That is, DHA is a protein, again a protein, DHA, and ALA. ALA is another protein. These are required for the synthesis of albumin in breast milk. In breast milk, ALA and DHA. DHA is present in breast milk, but DHA is not present in cow's milk. So that is why we say continue breast milk till 2 years or 5 years, so that a little bit of ALA or DHA goes. Otherwise, you have to supplement DHA. You have to supplement, like in newborn period, we supplement vitamin D drops, because vitamin D drops, if you don't supplement, baby cannot synthesize. Synthesize why? Sunlight gives the vitamin D synthesis. Sunlight forms the vitamin D, and newborns, you don't take them out to the sunlight and expose them to sunlight. So vitamin D is given from birth, 400 units in the first year of life. And from 1 year of life, you add vitamin D 600 international units per day till the baby becomes an adolescent by 12 years, when the LH FSH surge is causing the increase in the height and the weight. But the food calorie demand should be supplied by the parents, who are hardly conscious about it, because by 8.5 the baby is in class 3 or 4, by 9.5 the baby is in class 4 or 5, and the baby has started becoming tall. I remember I had a Chinese teacher in class 5, and when I started becoming tall, she used to pull down my skirt. And my cardigan, they were becoming short. So she used to say, Madhusmita, she had a Chinese twang, and Miss Lyson, I remember her name. She used to say, Madhusmita, you are becoming tall. Your mother has to knit. That time we didn't buy made up cardigans. We used to knit it. Our mothers used to knit those cardigans. So your mother has to knit more cardigans and buy you more cloth for your skirts. They have to be longer. We used to wear below the knee skirts. And now the girls don't heed about it. They wear hot pants and this and that. I'm not going into that. So anyway, so this is how you get the calories, and you need it for a 6-month-old baby. Simultaneously in adolescence you need it. And another thing which occurs in adolescence is menarche, which occurs in ladies, and iron deficiency occurs. Iron deficiency. I was telling you, I think in another pallor I was discussing in another video, I discussed pallor. There I think I should have mentioned that menorrhagia in females causes all over the world 9 to 10 hemoglobin per DL in this age group, that is adolescents and young adults, due to hemorrhagia, due to pregnancy, due to childbirth, they get pallor. And this pallor is looked after by Government of India. They give iron and folic acid to pregnant women, and now it is available for school children also. Another important thing that I can tell you now in this edema, this video itself, folic acid. Folic acid is another important thing. 5 milligram per day you need for open neural tube defects, because edema is a science which goes hand in hand with pallor. That is why I'm discussing this with you, because this 13-year-old girl, which I was telling you that in National Medical College, who came first time, she was discharged and she was admitted a few days later again with pedal edema, and that time in the pouch of Douglas we found a little bit of collection, and that was CB-NAT positive. That is, she had tuberculosis in that pouch of Douglas. So these babies, and especially the urban babies, I told you about that Gons focus. I don't know in which video I told you. I think in the pallor video you will get it, that Gons focus I've already mentioned. That Gons focus, it keeps sleeping in both rural and urban people. And rural people, when they come to urban for teaching or a job, what they do is they are exposed to more of crowding. They sleep in barracks in Howrah, what I've heard. They are sleeping in barracks in Howrah. And what happens is overcrowding occurs. And once overcrowding occurs, and this sleeping Mycobacterium tuberculosis, it wakes up again and spreads through the lymphatics and the bloodstream and the air passages and spreads to the lungs, causes miliary mottling, miliary TB, and pulmonary TB. I will discuss this. I will discuss tuberculosis in another video. I will tell this in more. But this tuberculosis itself, disseminated TB, causes edema. Disseminated TB will also cause both pallor and edema. Anemia of infection, which I have already mentioned in that anemia video, and this edema is due to hypoalbuminemia. You know, the liver is a powerhouse. What three things are formed in the liver? Number one is albumin. Number two is neoglucogenesis, that is, glucose is formed. And the number three is prothrombin. So in liver pathologies, like you know, in SAM, severe acute malnutrition, those babies from Ghana, those who had only calories, no protein, only tubers and roots, and the wasted children had both calories and protein deficiencies. Wasted, how do you detect the wasted children? They will have wasting in their axilla and their buttocks. You have to denude them of their clothes and tell them to raise their hands above their heads. Only then you can see the axillary pad of fat. It is denuded. That is, there is wasting instead of edema. Wasting for severe acute malnutrition. These are clinical signs. That is why I'm harping on these, because these are often missed by the undergraduate and the postgraduate. You have to see the buttocks. Buttocks, if you don't denude the baby of his pants, you cannot see the buttocks in folds. Buttocks are in folds. That is wasting of the buttocks. Wasting of the axillary pad of fat. These are signs of severe acute malnutrition. The baby who has come with bipedal edema. Bipedal edema. That is what I told you. In the diet, he is not getting adequate. The complementary feeding is not present at from 6 months to puberty. At puberty, tuberculosis has been added to the rural person who has come to overcrowding. Tuberculosis has been added. In addition, in America in the 90s, HIV was also there. HIV. You know, human immunodeficiency virus. HIV. Do you know many doctors in the United States were admitted in young adults and adolescents, as adolescents and young adults in the wards of America in the 90s. I know, because one of my uncles, not exactly uncles, he's a brother, cousin brother, in my in-laws side. He's a professor of medicine in New Jersey. What he told me was, the girls are all, the Indian and Pakistani girls and boys are all affected with HIV and tuberculosis. And HIV and tuberculosis go hand in hand. If HIV affects you, tuberculosis will flare. HIV will flare. So be very careful about edema. So I have told you about AIDS and tuberculosis. I have told you about nephrotic syndrome. I have told you about SAM. I have told you another immunocompromised is HIV. Let me tell you another experience of mine. I went to one of my close friends in NRS Medical College. She was a Tamil, and she got married to a Telugu family in Andhra Pradesh. She went to Chirala with a translation book from Tamil to Telugu. So brave she was, arranged marriage. Just she married a doctor, that MBBS doctor. She was also an MBBS. And both of them, from Tamil to Telugu, she was translating because she couldn't talk with the servants over there, neither the patients. And both of them went to Vellore, CMC Vellore. She did a DMRD there. And she came to Chirala. She was the only radiologist in a 250-kilometer area. Bapetla, near Vishakhapatnam. She used to go Bapetla, and she bought a echo Doppler to diagnose radiological diseases in Bapetla. So, and her husband, he was only MBBS. When I asked him that why didn't you do some post-graduation, he said, who will look after the children? Already 3 children had come. The eldest one has done MBBS from Ludhiana and MD in pathology. The middle one, the eldest one is Sweetie. She is in America. Her husband is a mechanical, her husband is Charles. He is a software engineer. He can play the guitar very nicely. He played it. And the youngest one is a boy. He's the naughtiest of them. And he named him Madhu after my name. Because she was so fond of me, she named him Madhu. They were twins, Madhu and something Meeta. I think Meeta expired and Madhu survived. Very, very naughty boy. His mother had to keep him in a hostel, a highly, what do you call it? The hostel had a high surrounding wall with glass pieces over the wall. And that boy used to run away from that wall and come home. So naughty he was. He was sent to Russia to learn medicine. He came back from Russia. Ultimately, he is an MBBS from China and he followed his mother and he did a DMRD from Nellore and is following his mother's footsteps in Bapitla. He is doing the color Doppler there. Why I told you this story is all her in-laws are doctors over there. All her in-laws. And in their in-laws' house, I saw them. One nursing staff was crying. Why was the nursing staff crying? Her husband was a driver who had a heavy vehicle license. Heavy vehicle license means you go for days and hours on a heavy vehicle. For days you are absent from home and naturally you can contract HIV. Those who have costume jewelry or gold or ornaments in the West Coast, for days they are there, they contract HIV from there, they give it to their wives and from there it gets transmitted to the baby. Now this is a cycle which was going on and on and on. From the east to the west, it was going on and on. So this HIV and TB was going hand in hand. Luckily now NACO has taken charge of it. HIV has been controlled. Bilateral parotitis in a baby means you have to look for, other than mums, you have to look for HIV. Bilateral parotitis, it comes very often in children. It is a sign of HIV in children. And any infection which does not, you have to take the history of the fathers being either drivers or jewelry and the gold and silver jewelry in the West Coast. These histories are very important for detecting the cause of edema. Cause of edema, HIV and TB associated with malnutrition. Now, I will come to another part of this nephrotic syndrome. Nephrotic syndrome, there is pallor because the kidneys, the kidneys are a place where erythropoietin is made. Erythropoietin is synthesized in the kidneys. So, whenever the kidneys are affected, supposing in nephrotic syndrome, all the glomeruli, there are podocytes, fusion of the podocytes in the glomeruli. The kidneys are affected, erythropoietin gets affected, and there is pallor. Less of erythropoietin means less of hemoglobin and more of pallor. There is stunting, height, shortening of the height. That is a renal dwarf. Renal dwarf means it is not due to the height deficiency due to malnutrition or HIV or TB. It is a kidney cause. Kidney cause. Kidneys are very important in our body, not only for the erythropoietin, but also they play the phosphate and bicarbonate buffers which are required for the maintaining the acidosis in our GI tract and in our skin too. We know that many soaps are available in the market, many soaps and many shampoos, they are gradually becoming defunct. Why? Because pH-friendly soaps and shampoos are coming in the market. Similarly, pantoprazole, omeprazole, that is the PPIs are available for the GI tract, probiotics are available for the, so these buffering is done by the kidney using bicarbonate and phosphate. So renal proximal tubules are the main place. You have to imagine, not only imagine, you draw the glomerulus, the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule, and the collecting duct, and which it goes out. So proximal convoluted tubule is the main part where the amino acid, the glucose, and the bicarbonate is absorbed. More than 60% is reabsorbed. And in Fanconi's anemia, what you get is glucoseuria, amino acid urea, proteinuria. Because why? Because this proximal tubule is defunct. Fanconi's anemia. And how do you detect it? Cystine crystals are deposited. You do an eye examination, you see cystine crystals. You understand why the baby is dwarfed, short stature, and you look for Fanconi's anemia. There is anemia, short stature, pallor in the palms and the soles, and there is cystine crystals in the eyes. You're dealing, and in the urine, you get proteinuria, amino acid urea, glucoseuria. You're dealing with a Fanconi's anemia. This is proximal tubular acidosis, and distal tubular acidosis is the pH of the urine. Whenever urine report comes, you see the volume, color, appearance, pH, specific gravity, this, that, lot of things are there. So there, the pH is very important. Why? Because the proximal tubule and the renal tubule both are important for maintaining the pH of the body. That is proximal tubular acidosis and distal tubular acidosis. Proximal tubular acidosis, the absorption of the albumin, protein, phosphates is done. In the distal convoluted tubule, hydrogen is secreted into the tubule by the effect of aldosterone instead of albumin, instead of sodium. Sodium-potassium exchange occurs. And this is done by the hormone aldosterone. Aldosterone. This hormone is working in the distal convoluted tubule, and in place of sodium and potassium, hydrogen is secreted into the lumen, and you get pH more to the acidic side. That is distal convoluted tubule, the urine is more acidic, and in proximal convoluted tubule, because the bicarbonate is being absorbed, bicarbonate pulls what along? Hydrogen ions along. And that will again be again in the loop of Henle. Again, you get water reabsorption, etc., etc. The distal convoluted tubule, another hormone acts, a antidiuretic hormone. Antidiuretic hormone is a lot of urine is not formed. Antidiuresis. That is, it prevents a lot of urine being forming. Controls the volume of urine. Otherwise, whatever water we have, we would have secreted it. We would have gone to the washroom and come back, But we are not doing it. Why? Because these hormones are acting, aldosterone is acting at the distal convoluted tubule. ADH is acting on the collecting duct and preventing the diuresis. Once you have tea and coffee, the ADH is becoming defunct and you have to go to the washroom. These act over there, the xanthophylines act over there. So this is how it acts. And so I will come back to renal edema. Renal edema, you get associated pallor. You get associated stunting. I told you in short stature, I told you renal short stature. You get acidosis, proximal tubular acidosis and distal tubular acidosis. In some radiographs of the abdomen, Banu must be getting it, there will be calcinosis of the kidneys. Whenever we get calcinosis of the kidneys, we suspect that must be proximal tubular acidosis or distal tubular acidosis. Can you tell me whether it will be proximal or distal? If the calculi are found in the whole of the abdomen, you just use alkali mixture. You just give bicarbonate by mouth and it is corrected, because the hydrogen which comes out, it is corrected by that alkali. You give it in very small dose and it is corrected. That tubular acidosis, that is calcinosis. And what do you monitor? How do you monitor? How do you monitor renal edema? You have to maintain, number one is the weight. That is, as the weight decreases, edema decreases, the weight will decrease. Number one. Intake output, that is how much water the baby is taking and how much the baby is excreting in the urine. So in adults, there's a fixed amount, that is 600 ml. We add. In young adults and in children, we don't do it. In very young adults, we add 400 ml. But intake output is a much better way, because in intake output in hospitals or nursing homes, you can measure the intake, how much water you're giving and how much water is being produced. Unfortunately, the sweat is not measured. Sweat or the perspiration is not measured. But the urine can be measured, I told you, by diapers, by measuring the diapers and by measuring the catheterized bladder. If you catheterize the bladder in the both the male and the female, you can Foley's catheter in case of females and ordinary rubber catheter in case of males. It can be Foley's also. You can measure the intake and the output. Blood pressure, hypertension. Hypertension is an important feature of APSGN, acute post-streptococcal glomerulonephritis, whereas hypertension is absent in nephrotic syndrome other than non-minimal nephrotic syndrome, which occurs in bigger babies, that is above 8 years, that is in adolescents and adults. Lupus nephritis and other causes of nephritis, which is focal sclerosis or IgA nephropathy or lupus nephritis. It may be of 4 or 5 types. Then there are other causes of non-minimal nephropathy, which you have to diagnose by renal biopsy. Unless and until you do the renal biopsy, you cannot detect this non-minimal biopsy, because you need to see the glomerulus, whether it is focal sclerosis or it is mesangial or it is mesangial sclerosis. You have to differentiate this differentiation of the glomerular filtration and the polymorphs and the antigen, antibody, IgA, podocytes, etc., etc. You have to do the biopsy of and biopsy of the kidney is another separate thing which has to be taught in a separate video. It is very important and very carefully it has to be done under USG or CT guidance. It cannot be done other than USG or CT guidance. It has to be done under USG and CT guidance. So I am now in a private medical college. We are deciding to go into peritoneal dialysis and CT guided, because peritoneal dialysis we use in small children. We don't go for hemodialysis, which is used in adults. And similarly, dipsticks. Dipsticks is a colorimetric assessment of the urine, by which in color you can measure the pH and the protein, and that is done in dipsticks. Infections you have to see. Infections, I told you it's immunocompromised, selective proteinuria, I told you in APSGN. Similarly, in nephrotic syndrome, a lot of selective proteinuria occurs. So the immunoglobulin and complement is going away. So a lot of immunodeficiency occurs. Immunodeficiency means infections, very silent infections. Silent infections means a nephrotic syndrome baby may be very silent, may have peritonitis, but may not have the cardboard rigidity associated with it. The abdomen may be soft. So what you do is, whenever you see a nephrotic syndrome baby, you measure the temperature. You measure the temperature, that is the mouth you use, the temperature you see. You place your hands on the stomach. You ask the patient any abdominal pain or any associated disturbance in your abdomen. It may be a peritonitis. Very, very, very common peritonitis and this infection and this fever. These are all signs and symptoms of infections in nephrotic syndrome. It may be a silent peritonitis which is going on for days, and then you see the baby comes with a bloated abdomen, and then you can't do anything, baby passes away. So non-minimal nephrotic syndrome has to be detected by renal biopsy at the initiation of treatment, and only then. Nephrotic syndrome needs steroids only for treatment, but over here we use rituximab and other medicines. So there, in case of non-minimal, you need to do the biopsy before starting rituximab or other medicines for nephrotic syndrome. This is the face of a baby which is slightly bloated, slightly edematous. You can see the lower lip, it is hanging in front of the mouth. Hanging in front of the mouth, you can see there is puffiness of the eyelids. puffiness of the eyelids. Can you see the puffiness of the eyelids? It is visible very nicely. And you can see the lips are also edematous. The whole lips are edematous. Even the facial contour, it has increased. It has increased. The lower lip is hanging down in front of the, a little bit of teeth is showing, that is lower lip is, it's pendulous. The term which you use in medicine is pendulous lower lip. And there is a bit of puffiness of the eyelids. So this is the early edema in acute post-streptococcal glomerulonephritis. If this mother, the mother of this child, says that the baby is having cola-colored urine, you be very cautious. Your antenna should be up that you are dealing with an acute post-streptococcal glomerulonephritis. This is the only visible phase that you can see. There may not be any edema in the legs, there may not be any edema in the stomach or the hands or the limbs. Only this facial edema along with cola-colored urine is enough to diagnose acute post-streptococcal glomerulonephritis. Mother, you can ask the mother, did he have a sore throat 2 weeks back? Did he have an impetigo 2 weeks back? Mother may say, I don't remember exactly. But on the feet, on the legs, and you can see the light scars of the impetigo. Or you may see scabies, furrows on the fingers and toes. If you ask the mother repeatedly, did you have some itching? Did you also have some itching? Some other member in the family had itching. The history of scabies will come out. So history taking is very important in all pediatric diseases. This is just an example.